going to open up to the floor. You can make comments, questions. I know there were some questions particularly related to, I think Bruce raised the issue, health home, care coordination, sports and supported housing. Kind of what is the vision and how is that going to look? So, those are questions I know that I've been getting, and I don't know if other people are feeling that, because I think some of the questions that supported housing providers through the years have felt, well, they were the core of coordination. And now that coordination through health homes, has possibility. Where does the housing provider actually sit in that relationship, or do they become the care coordinator? So I kind of throw that out maybe as the first question, because I know it's on the minds of a lot of housing providers.
Sure. I'm fully aware that probably one of the biggest challenges, if not the biggest challenge that we face right now, is that there's so much going on all at the same time that creates a lot of sort of confusion, and with confusion comes nervousness, angst, fear out there in terms of what this change will mean and what's the direction, and how these various reform initiatives, sort of all pursued simultaneously, are going to affect providers, people on the ground who've been working and serving these populations for many years. I wish that we were in a situation where we could pursue reform sort of in a slower time frame. But not only is there a state budget reality that has required us to move at this pace, but there's also a federal budget priority that's out there that the federal government hasn't quite gotten their act together, but they're facing the biggest budget deficits in the nation's history. And eventually, those groups, members of Congress and the President, will eventually, I suspect, get their acts together and will be moving in a direction towards trying to contain costs in entitlement programs, including Medicaid. And I think part of the sense of urgency we feel around implementation is that we want to be prepared for an environment where we will have to function with less federal money. That is just, I think, the reality we will face. The question is when. And I think we have this window here to try to get these strategies in place, to work collectively to try to make sure that they're done in a way that, as I say, protects what's good about the system but addresses the sort of core problems. But back to this question, how do these various strategies fit in, particularly as it relates to support of housing providers? So the direction the state is going, and I think if there's been one message that we've been clear on as opposed to others, is that we are ending the fee-for-service Medicaid program. We are on a path. It may take us, 3 to 5 years to fully accomplish that vision. But our goal is to get out of fee-for-service, to move all of the members and services that the Medicaid program funds, or virtually all of them, into some form of capitation. What remains to be determined is a little bit what forms those take and what structures are put in place to provide protections for both providers as well as members. But that is the overall direction we are going. In addition, we are serious. We do not see it as a temporary phenomenon. We are building health homes across this state for the long haul. We have invested tremendous amounts of time, money, and effort. And I know health homes in particular have generated a lot of angst in terms of what they mean and, am I a health home lead? Am I a member of the network? If I'm a member of the network, how will individuals be assigned to me? What will be my role versus what will be the health home's role? But we do see that health homes are a permanent feature of the delivery system. We really see health homes to a great extent for our most complex Medicaid patients, many of whom we're talking about here, the ones who need supportive housing. We see them as really an integration tool at the provider level. Managed care is one way to begin to better align incentives within the delivery of healthcare services, but it is not the be-all, end-all. We need to have providers, and I use provider in a very general sense, not only supportive housing, but other human service providers, local units of government, individuals working together collectively to look at the aggregate needs of individual patients' members. And building health homes from scratch when no one else has done it in the country is a challenging process. And of all of the initiatives that we're pursuing, it's probably, in my view, one of the most exciting, but I know in the views of many, one of the scariest, because it potentially is a systemic change in how we integrate services at the provider level. That integration has the potential to mean that providers will share information electronically for the very first time. That is a diverse set of providers who will be able, when they see and touch a patient, a member in a particular setting, they will be able to communicate with others who are better situated to meet some of the needs of that particular member. But our hope is that we'll have individualized care plans unique to the individual, that are holistic, that are integrated, that information is shared, and that as a result, we are for the first time on a systematic basis looking at actual human beings and their needs, not looking at it from, I'm part of this silo, I only look at this person from this perspective, if it's a behavioral health problem, if it's a healthcare issue, if they've got a substance abuse problem and I'm a primary care doctor, that's not really my responsibility. I'm treating their diabetes. We have to get out of that mindset, and really health homes for those really challenging patients is our strategy. Now, how does that work with supportive housing? I think at the end of the day, as supportive housing providers, you are in a tremendous position. Why? Because you are providing access to a service that is really vital. I think, as we all know, the number one determinant of health for many of our patients in terms of are they going to be on a path to recovery, are they on a path to stability, is determined by whether they have access to housing, particularly housing that can provide them with the supports they need. There isn't enough of that in the city of New York or in the state of New York. And so you guys are uniquely positioned to be a vital member. What we need to do is make sure that health homes you are integrated with them so that when the health home comes across a patient who's chronically homeless, who needs stability in their lives, who needs supportive housing, that they have an opportunity to be able to refer and basically assign one of their health home patients to you because you are the best organization situated to meet the needs of that particular member. We also need to make sure that you're integrated with those broader set of providers, that you're able to share information with the broader provider community, that you're able to ensure that the people you serve have access to the broader array, as Amida Care has mentioned, in terms of the broader array of specialists or other types of care providers. And we think health homes in partnership with managed care organizations are potentially the vehicle to achieve that. So, in my view, health homes are exciting. And we've got some really innovative models. They're still very much a work in progress. What they look like today versus what they look like 5-10 years from now is going to be different. What I feel like I take some solace from the fact that when I look at particularly the state of New York's effort and the city of New York's efforts around fighting the AIDS epidemic, what the state was able to do with a significant investment of resources in building, the only AIDS SNPs of its kind in the country, as well as building a variety of different providers who are able to meet comprehensive needs. And really, for us, we're, in a lot of ways, some of the AIDS providers were really our inspiration behind what a health home could be. That gives me a lot of confidence that if we could really take on the fight against the AIDS epidemic, that we can expand our worldview and look at other patients with other chronic illnesses and look at them in a comprehensive manner. And if we, working together, and I know there's going to be transition issues and things to work out, that I think we can find a way to fuse these strategies together in a way that leads to that win-win, better outcomes and lower costs.
Adam?
I would just add that I think this issue of, we've been dealing with the issue of coexisting care managers, case management, supportive housing, a variety of settings for a while. Health homes is sort of exploding that issue to a much potential larger scale. It's an ongoing one, and this division of labor question is an important one. And as you and Jason have said, I think to the degree that we can be very explicit about the ambitious but reasonable expectations of what the models of service can achieve, what the capacity from a training, staffing level is, what a reasonable division of labor in a very explicit way will go to trying to figure out these important issues. But I think there's been a lot of work on this already. But it hasn't, it never did, I don't think it ever resolved the issues that we've been dealing with for a long time, and perhaps this is an opportunity to do it in a much more concrete way.
Any questions? Let me start at the front. I'll work my way back. How's that? And I got to look at both sides. So there's someone from the network here that can maybe help me out with this? Because no? Okay.
Paul Feuerstein from Barrier Free Living. We have been working to address the issue of nursing home conversion for the last 22 years. And one of the big challenges which we faced is the lack of transparency about data. Question 1A of the Health and Human Services surveys of nursing home residents is, would you rather live in the community? Finding that information for New York City nursing home residents was a heroic task. I hired a consultant to do it for us. He said it was easier to pry secrets out of the KGB than to get that number. And I finally got it from somebody in Syracuse from the third quarter of 2010, CMS site. I went back to the CMS site again this last week to update our numbers, and they still have the third quarter of 2010 as their latest. So there were 9,200 people living in New York City nursing homes that didn't want to be there. At that point, at a cost of about $1.2 billion. I've been told my numbers, $128,000 per person per year, are old numbers, but I can't find out what the new number is. Those are the kinds of numbers I know I need as a provider to make the needs case when I am going to DOH or going to whoever to say, I want to create beds in nursing homes, to convert people from nursing homes. How can we work together to make that a more transparent process so we're not bumping up against these sort of concrete walls of protectiveness in nursing homes?
Well, yeah, I mean, I think that I'm a big believer that in healthcare you get what you pay for, in the sense that the financial incentives that are created within the system leads directly to the manner in which care is provided, and you know, and it's very, very challenging, very difficult oftentimes. And I was mentioning earlier, you have to be a social entrepreneur to find ways to go against those incentives, to do things that, you know, your average person would say is the right direction to go. I think in the case of the long-term care system, it is very clear that the financial incentives are very much not aligned. I mean, for instance, the example that I've given is that a hospital has an incentive to get someone out of their hospital as quickly as possible. Nursing homes have a strong financial incentive to fill every available bed. They work together, hand in glove, to try to get patients out and get patients into the nursing home. Once the patient is in the nursing home bed, they have no financial interest, in fact, a disincentive to try to work to move that patient out into a community-based setting, even if it's what the patient might want or what is best for the patient. You know, you're going against, and even more perverse than that, with the way we pay on bed hold within nursing homes actually have a financial incentive to create churn, to have some number of their patients in the hospital for some number of days in a given month, because they get paid for a bed that is empty for up to 15 days. I mean, our system goes against, our finance goes against the system what we want. And I think that's where, I think I mentioned earlier, the statistic that when you look at the only state in the country that's had managed care since its existence, and they spend 80% of their money compared to us spending 50% of our money in long-term care in the home and community-based setting. I think that's a clear example of that our financing system within the nursing homes, and you know, and what financial incentive does a nursing home have to provide data that would assist someone who working to relocate people out of the nursing home? And the answer is zero. And so I think as a state, we need to find ways creatively to get data into the hands of people who are working in the best interests of members, in the best interests of the state's new direction, so that we can all be more successful.
Anyone else? Panel?
I'm Mark Hurwitz from Project Renewal, and I think similar to Donna's question about the role of case management in supportive housing, a lot of us that operate supportive housing are thinking about what's the future of the sort of gatekeeping function that has traditionally been done by our funders in government. And as you talk about all of the Medicaid recipients being enrolled in managed care, I think the managed care plans tend to think of, we want to authorize the service and for a certain amount of time. And supportive housing is permanent housing with tenancy rights, so you can't really authorize a limited length of stay. And a lot of the existing stock is sort of under these New York agreements that have very specific rules about who's qualified and how they get in. So do you have any thoughts about how that gatekeeping function will change?
Right. I mean, our intent, we see supportive housing, and I think as you mentioned, individuals enrolled in supportive or who are in supportive housing have rights. In no way, shape, or form would we, in any of our efforts, want to take away anyone's rights to supportive housing. In terms of the gatekeeper role, and I think this is an important question, I think that and when I talk to the plans or I talk to the health home partners, the issue that I hear is not, wow, we want to find a way to keep people out of supportive housing or to minimize their stay in supportive housing. What I hear much more is there's just not enough out there. And as you give us more and more complex patients, our concern is that we won't be able to manage their costs because there are needs that we can't meet. And that's really what I hear more from the plans, and Doug, spends time with his colleagues, but that's more of what I hear, which is, they're on the hook for those, the inappropriate hospitalizations. And if they can't find a way to get someone into a stable housing situation because there just aren't options available, that's a big problem. So, I mean, yes, there are transition issues. There are things that we need to do to make sure that as we move these patients into managed care, that we do it appropriately. But that's what I think is that you're uniquely situated as providers because you provide a service to which there is just not enough access. There's just not enough options. And you're very necessary for the kind of patients we're talking about.
Yeah, I actually think there's some hope that in the flexibility of the big waiver in particular, that some of the services that we think we could wrap around individuals in housing when they're in crisis, particularly, or would be a benefit, so that we haven't always had the opportunity. I'm speaking now as a provider, but to really. Sometimes we know what a person needs, but we can't get it to them. They're not going to go to the clinic. They're not going to go to that's not the answer. But so I think there's a hope that with the waiver, there'll be opportunities for more person-centered wraparound services. So.
Can I just add to that? In part of one of the most interesting things Jason said earlier was the extent to which he's really stressed at the state level with regard to his staff support and all these issues he has to resolve. And I worry that to the extent that gatekeeper role is shifted further away from the locality, that it might not be as effectively delivered, especially if it's not supported with appropriate funding and resources. And that's why I did mention the extent to which we do provide for eligibility for New York 3 housing a role. And I think that the state has to really think carefully about a new approach or a different approach that and make sure it's going to be better and more effective than the one that exists or the one that we've already got in place.
Okay. Your hand's been up for a while, I'm sorry. I'll get to this side of my promise.
Bonnie Stone from Women in Need, and you're a provider of family support housing. And it's interesting, I didn't hear a word about families and children, and certainly in the homeless world, families are a huge part of it, and in supportive housing, they're a minuscule part of the planning. The New York 3, finally, when it came out, it had a 10% were set aside for families. So I think we're decades late on the family side, and healthcare is focused on individuals. So I don't know how that integrates with all this planning, and I'd like to make sure that it's on your agenda, because it's all these young women with issues, with problems, with illnesses, and their families. And I don't hear anything. I didn't hear a word about that.
Right. No, I think that a very reasonable critique of a lot of what we've been focused on in Medicaid redesign is that we have been very focused on the patients who are generating the most cost in our system. And those tend to be and we have not spent as much time on families and kids as we really should moving forward in the future. I think that for supportive housing, as we look to the waiver, I think there's potentially some opportunities to think a little bit more broadly than we have. I mean, my one critique on supportive housing is when I look at it from the outside, I see it's sort of a siloed approach, right? It's diagnosis-based. Do you have AIDS, HIV, or not? Do you have a mental health or behavioral health issue or not? And then you can see people who fall through the cracks between those diagnoses. And I full well, having gone out to Kohler Goldwater, yes, and toured it and saw people who are in Kohler Goldwater for extended periods of time, years, 4.5 years. And now with we have an initiative, thanks to the partly thanks to the $75 million from the ART, to actually try to create housing options for them. But there are clearly individuals, and it sounds, families as well, in particular, who are the majority of who's homeless at any one time, that are falling through the cracks. And I think we have to think a little bit more broadly, but defer to others on the topic.
Yeah, I would just, emphasize that not all the Medicaid money should run through the plans. I mean, the approaches like the $75 million, I think as we work with the state to advocate for what this position with the federal government should be, when you have complex problems like families or other populations, there needs to be some more global approaches that work through local government. And so it becomes a balancing of how much of the Medicaid dollar is going to go through plan and how much with these savings that the MRT is generating, that they go out for some form of capacity building, perhaps for special populations and people with special needs. It's a good time to raise that discussion.
Right.
Yeah, and I want to follow something that Paul said. Part of the dilemma is, as everybody said here, there's just not enough stock. There's just not enough capacity. But the other dilemma that we find, as relates to our Kohler Goldwater residents who don't need to be in an institutionally based long-term care setting, is that even when we have a housing provider or a transitional housing provider that has capacity, the folks that we need to help get placed, they're not HIV/AIDS, so they can't get the rentals, and they're all very low income. They can't get the rental subsidy. So the issue, and I was intrigued by Bruce's statement, and of course, Jason, we talked about this. There's got to be some flexibility in terms of that basic rental support. We can all talk about HUD needing to do it, but we know that in New York City, there are thousands of other very low-income people in the community who need housing as well. But we're spending hundreds of thousands of dollars per person for those many years for want of this housing. So if there's a way that we could figure out, perhaps through the waiver and even before the waiver, some solution, even if it's on an interim basis, for that rental support when there are the slots available to individuals as we work through this multi-year waiver process. And ultimately, when the system will begin to make sense and pay for what really is needed.
I think I have one more question, because I've been told we've got to get to the, so.
David Beer from Common Ground. I was wondering if the Supreme Court overturns the President's health care legislation, will that derail any of the state's Medicaid redesign initiatives?
Good question. The answer is it depends. Typical government response, yeah. But it's honest truth. Is that we're going to be watching with bated breath. The latest date I have is estimate is June 25th that we'll see the decision. Even after the decision comes out, it'll depend a lot on what the decision actually instructs the Department of Health and Human Services to do about this. We did implement some important initiatives that were linked to the Affordable Care Act. Health Homes is an example where we're getting 90-10 funding. So we're going to be now, this waiver, for instance, could potentially assist us. But we also have expectations around, we talked about the state's role versus the local role in administration of the Medicaid program. One of the biggest challenges we have historically is that we have a very antiquated eligibility system. It's mainframe based, been around for 35 years. It desperately needs to be replaced, and actually we're trying to use the health insurance exchange as the vehicle for beginning that process. We really want to escape from an environment where that in order to sign up for health care services, you got to go down to a county welfare office, or you got to go fill out tons of paper and things like that. We really want to, I call it rehumanize the process. But we're sitting on $88 million of federal money that we've already gotten that can go a long way towards building a new system, regardless of whether there's a health insurance exchange or not. Will we be able to keep that $88 million and spend it on a new eligibility system, even if it's not for a health insurance exchange, but just for Medicaid and for SNAP and for other programs? Our hope would be the answer is yes, but they're still to be determined. But our real thought in all of this, and we say it in the waiver document, is we really see the waiver as having two purposes. Purpose number one was to fully implement the MRT multi-year action plan to really help us basically cement this new approach to Medicaid reform, to really allow us to be able to smooth transition, to assist providers, to assist members as we make some of these real significant changes in payment systems and in delivery systems. But then we also say very clearly that we want to use these dollars to help us prepare for the 1 million new New Yorkers who are going to get access to health care because of the Affordable Care Act. Tremendous opportunity for us, because so many of the people who we end up with in our system, and we have a more progressive system than any other state in terms of child cell coverage and things like that. But there are individuals who end up in our systems who, if they had access to primary care or behavioral health services or other things earlier on in their lives at different points, if there had been interventions, things that could have helped them, we would not be dealing with some of the things that we're dealing with some of the costs. But that's only possible with the Affordable Care Act. So, I can't give you a definitive answer in terms of it, but, we remain very hopeful that the court will see in the president's view. So.
Okay. All right, with that, I want to thank our panelists. It was great. We could have spent the whole day here, and thank the audience. Thank you.